Hello, and welcome to Stanford Med Matters. I'm Dr. Sharon Hung, the Director of Women's Health for the Primary Care and Population Health Department at Stanford. Today, we're diving into the intricacies of women's health. Joining us is distinguished expert in the field, Dr. Karen Adams. She's doubly boarded in obstetrics and gynecology and lifestyle medicine. She's a clinical professor at Stanford University School of Medicine and is the Director of Menopause and Midlife Program at the Stanford Healthcare. It's a pleasure to have us with you today, Dr. Adams. Thank you so much for chatting with me today about perimenopause and hormone therapy.
Dr. Hung, it is absolutely my pleasure to be here with you. And, I think we could go on for 3 or 4 hours, but we'll do our best to keep it to a manageable amount, right?
Yeah. So I wanted to start by asking you, what motivated you to specialize in menopause and healthy aging?
Mm. Yeah, it's probably been 15 years or so that I've been focusing in this area. I started out as a general OBGYN physician, delivering babies, doing surgery, taking care of all ages of women. And actually, it's kind of funny. One of my roles was to be the residency director. I was in charge of training residents across the whole spectrum of OBGYN care. And one of the things we were required to teach was midlife and aging. And because people get out of training and they're really good at delivering babies and they're great at starting people on birth control and all of that, but they didn't see a lot of women 45, 50 and older. And we looked around our curriculum and we found we really didn't have that much. And so I created a clinic we called it the over 40 clinic back then. And then it just kind of went from there. It became my real clinical interest. And as I became more, all of the issues of the women that I was caring for became more relevant to me myself as I aged. My patients were aging, I was aging. It just got more and more fascinating to me. And I have just really enjoyed that part of my career. And it's been really fun now because menopause is so much having a moment that it's really great to be at this stage of my career and at Stanford where I can really make a difference. So that's my story. That's how I got here.
That's really inspiring that you saw the need for such a clinic and started one.
Oh my goodness. And we can talk about that as we go on, because the Women's Health Initiative data came out, and I know we're gonna talk about that. But there were 15 years in there in the early 2000s until 15 years later that people didn't get trained. And what they got told in medical training and nurse practitioner training and all of it was just, no, we're not going to do hormones and we're not going to talk about that, and we're just going to move on. And so now we're really not only trying to educate our patients, but we're also trying to educate providers, people who didn't get that training. And so that's why things like this are just, I just love doing something like this where it can really elevate the conversation all across the board.
Yeah, and I've already learned so much from you since you've joined Stanford in the last year, so we're so lucky to have you.
Oh,
Before we jump in, why don't we start with some definitions? What's the difference between premature menopause, early menopause, perimenopause?
right. So the definition of menopause is no period for a year. And you only know that in the rear view mirror, right? You don't know when you're having that last period. It's only a year later that you say, oh, that was it. So it's a year with no periods. On average, it's age 51 in the United States. And the time leading up to that is called the menopausal transition or perimenopause. What we used to call premature ovarian failure, we now call it premature menopause or premature ovarian insufficiency, by definition happens before age 40. And that can happen naturally for some different reasons, but it can also happen due to medical intervention. In particular, cancer treatments often can cause premature ovarian insufficiency. or surgery if you have your ovaries out for some reason. That can put people into what we call surgical menopause. But any menopause that occurs earlier than age 40 is considered premature. And then early menopause is anything that happens 45 and younger. So that window of 40 to 45 is early menopause. Anytime after 45 is considered normal. So that's kind of how we think about those definitions.
Got it. Thank you for reviewing that. And so let's delve into perimenopause. How long does it typically last?
Boy, right? Yes. And so to me, 45 seems really young, but that's when it really starts to kick in. So with menopause being on average age 51, the average transition time for perimenopause is somewhere around 4 years, 4 to 7 years. So if you back up from 51, usually in the mid 40s, people are starting to experience that menopausal transition or perimenopause. So it's really important to have a high index of suspicion in your clinical care to start thinking about perimenopause as a possible cause of symptoms.
And I think there's this assumption that perimenopause has to start with a decreased frequency of periods. But what are some common symptoms that women might notice before or during perimenopause?
Right, right. So the primary symptom that 100% of people get in perimenopause is that skipping period. So, and the reason that happens is because if you think about your period as your fourth vital sign, and I know we think about a lot more than three vital signs or four, but I think of it as the fourth vital sign or a vital sign. So there's your temperature, your pulse, your blood pressure, and your period. And when you have a period each month, what that tells the patient and me is that the brain is sending a signal to the ovary every month, and it's doing that very consistently, and the ovary is responding very consistently every month. And so the brain talks to the ovary responds by making hormones, and it's very predictable. Every 30 days, every 28 to 30 days, the same thing happens. Estrogen goes up, comes down, you ovulate, your progesterone goes up, comes down, you have a period. And that just happens very consistently. Now, in perimenopause, the brain is still sending that signal to the ovary the way it always has. It's doing its thing, but the ovary is aging. And as the ovary ages, it responds less and less consistently to those brain signals. And so, the brain's talking to the ovary's sitting back going, nah, not going to do it, not going to respond. And then it wakes up and it goes, okay. And you get this huge surge of hormones and then a big drop. And it's completely unpredictable. So you have a period, and then 2 or 3 months go by, no period, and then you have a period, then another few months, and then maybe you have periods again for a few months, and then so people say, yeah, it was weird. I thought maybe something was happening, but then my periods came back, so I figured it was fine. And that's typical for perimenopause. It's irregularly irregular. It's sort of like the atrial fibrillation of hormones. And so because it's unpredictable and irregularly irregular, and can you imagine on average that goes on for 4 years, that's what triggers the symptoms. And so people's periods are becoming irregular. But in addition to that, even before periods have stopped completely, 80% of people with ovaries will experience hot flushes. So hot flushes and night sweats happen to about 80% of people. And all through this vodcast, I'm going to say women, but I understand that not everybody who has ovaries identify or call themselves women. But if I say women, I want that to be understood to be inclusive of anyone who has ovaries. So anyone who has ovaries is going to start having hot flushes. 80% of people have hot flushes. And so 100% of people start skipping periods. 80% of people have hot flushes and night sweats. So So those are sort of the big red flags for clinicians. And then there are some other symptoms in perimenopause as well that we can talk about that sort of extend on into menopause.
Hmm. And so I think women get really confused when all this starts to happen. And first question they often ask is, should I have some hormone testing? How do you generally respond?
Yes, that's a really, really common question. And it makes me sad, actually, that there are so many online portals and things where people can spit in a thing and send it in. Because if you understand the physiology of what's going on in perimenopause and you understand that it is irregularly irregular, that things are up and down and all over the place, then it starts to make sense that if I drew your hormone levels every week for 6 weeks, sometimes they're going to be up and sometimes they're going to be down, and they're going to tell me nothing other than what your period has already told me, which is that you are having irregular cycling. Now, if I'm concerned that it could be thyroid or it could be a pheochromocytoma or something like that, then I might get some testing. But if this is consistent with perimenopause and she's had her thyroid levels checked and that sort of thing, hormone levels are not going to tell us anything, you and me, Dr. Hung, that we don't already know from the way her periods are behaving. So hormone testing is really not useful in this situation. Perimenopause is a clinical diagnosis.
Hmm. And I've seen some studies discussing anti-Mullerian hormone, AMH, to predict the final menstrual period. What are your thoughts on that?
Right. So AMH is a marker of ovarian reserve. And I say that with air quotes because what it is primarily used for is to determine how well a woman or a person's ovaries will respond to a stimulated cycle, meaning IVF. So it gives you some sense of how responsive those ovaries will be if they try to be stimulated to harvest eggs for IVF, but it's not used as a clinical marker for perimenopause or menopause, and there's no real correlation of it with any clinical outcomes. I do want to circle back to symptoms because we talked about skipping periods, we talked about hot flushes and night sweats, what we call vasomotor symptoms. Some people have them in the day only, some people have them only at night, some people have both, but they are pretty unmistakable. And if someone says, yeah, I'm kind of warm most of the time, is that a hot flush? The answer to that is no, because it is so clear. I mean, it's visible. People can see it. You know, your face turns red, you're sweating through your blouse, you're sweating through your hair. And it can even feel like a panic attack a little bit. It can feel kind of uncomfortable. It can feel like heart racing and that sort of thing. So 80% of people get that. About 68% of people in the perimenopause and menopause can get mood disturbance. So anxiety, irritability. People can feel like they have PMS, except it's not predictable. You know, with PMS, it's every cycle right before your period, it's kind of cyclic, and then you have your period, you feel better, and then it comes back around the next month. Because again, when you understand that hormones are irregularly irregular, you can see why those mood symptoms can also be kind of random. And that's really disturbing to people because they think they're losing their mind. They're like, I don't know from one day to the next how I'm going to feel. And I just feel like I'm PMSing all the time. And it's because your hormones are so unpredictable that it's really triggering those mental health symptoms. So it is really important, I think, for us to recognize that 1 in 4 women will experience an episode of major depression in the perimenopause and early menopause. And people, even without a history of major depression, are 2 times more likely to have it in this period of time than in other times in their lives. But There's also this thing called perimenopausal mood instability, which doesn't meet the criteria for major depression, but is manifested by mood symptoms. So we need to think about, is this major depression or is it perimenopausal mood instability? Because the frequency of this ranges from 40 to 68% in the perimenopause. And I really want to highlight this because this month there has been a series of articles that have been published in Lancet about menopause. And one of the articles is about mental health conditions and does perimenopause and menopause increase the risk for that, and are those more frequent? And they actually came out and said that that's not true, and that the risk of mental health issues in perimenopause has been overstated. And I have to just say that that is a very controversial article, and there are many, many menopause experts in the country, myself included, who disagree with their interpretation of those findings, and that there are hundreds of articles linking menopause and mood disorders. And so that's controversial. It's happening right now, and I just want to acknowledge that that's out there, but that's not the final word. So hot flushes, mood disturbance, sleep disturbance is another symptom. Vaginal symptoms, about 50% of women experience vaginal dryness and actual pain with intercourse. So it's a lot. And sometimes these things are all happening even before periods have stopped completely. So again, my message to the people listening to this podcast is have a high index of suspicion, and don't discount this as possibly being perimenopause just because she's still having periods now and then. So that's a lot. I'm going to stop and take a breath, and yeah, we can you can think about that and see if there's anything you want to follow up on.
Yeah, thank you for raising awareness about that. I'm curious, you mentioned, it's important to kind of tease out if it's perimenopausal mood instability versus something like major depression. Would the treatment differ depending on what you thought it was between the two?
Yes. Oh, and I'm so glad you brought that up, because in this, there's a really wonderful article that was published in the journal Menopause back in 2018, and it was the first ever guidelines for diagnosis and treatment of perimenopausal mood disorders. And it's excellent, and I really recommend it to our listeners today. And what they found when they reviewed the world's data on this is that if it is perimenopausal mood instability and not major depression, estrogen works to stabilize the mood in perimenopause. And we can talk more about that, about ways we might treat that. But estrogen is as effective as traditional antidepressants in treating perimenopausal mood instability. But, the way we diagnose major depression is with the PHQ-9, and you go through and you get that sorted out. But, there's a lot of overlap in the symptoms with perimenopause. There can be sleep disturbance, and there can be feelings of sadness and that sort of thing. So you want to use the PHQ-9 to make that diagnosis of major depression. And if somebody has a history of major depression, or if that's what you've diagnosed, then those people really should be treated primarily with antidepressants, and treat them as you would treat a person in major depression, and consider the use of estrogen if you're treating menopausal symptoms in addition to the mood stuff. So for example, hot flushes and night sweats, you might want to add the estrogen in addition to your antidepressant, or you may want to choose one or the other, because you get some benefit with the vasomotor symptom treatment with the antidepressant, with an SSRI or SNRI, and then only add the estrogen if they still need it for vasomotor symptoms. But my important point for you and for our listeners is major depression should be treated as major depression. Perimenopausal mood instability can be and should be treated with estrogen.
Great. I'll definitely look into that article. Thank you for that advice. One thing you mentioned was that some people might only hot flash at night, or they can have symptoms that are associated with kind of panic attacks. And so, as a primary care provider, when I evaluate night sweats, I do a workup with, chest X-ray, CBC, CMP, all these things. Do you feel like that's necessary? And also, when people kind of describe these panicky palpitations, I feel the need to do an EKG, maybe a Zio patch. Do you feel like those are necessary as part of the evaluation, or is there something about the history that can be reassuring that it's just part of their perimenopause?
Right. Oh, I think that's a great question. And really, honestly, I have so much respect for PCPs because my goodness, you guys do everything. You do everything. It's so easy for me to be an expert in menopause. I haven't taken care of a man, in decades, 30 years, And when I think about when you come into clinic and what is on your schedule, and what you're going to deal with that day, all I can say is I bow to you. I bow to you because it's a lot. And you are the quarterback, really, for your patients. And you're the one who's deciding, does this person need to see the gynecologist or the cardiologist or the rheumatologist? And I can't even imagine. Having said all that, I would say I would defer to your judgment as a PCP, in terms of, what do you think about these palpitations? I would just say, yes, sometimes that's a manifestation of perimenopause and menopause. And Oprah is probably the most famous person who has gone public saying she had $1 million cardiac workup for palpitations when it turned out that they were associated with her perimenopause and menopausal transition. And she
Mm,
had a completely negative workup. And then when she started on hormones, her palpitations went away. So, that is very individual. And I would have to say, in my own practice, it's not a common presentation of perimenopause. And it's not so much true that sense of your heart beating out of your chest and you can't catch your breath and that sort of thing. But there definitely is some association with that in hot flushes. And so I think I would leave it to your clinical judgment in terms of whether or not you think a further cardiac workup is indicated, or if you would maybe do a short-term trial, maybe 4 to 6 weeks of hormone therapy and see if that resolves the issue, and then only work up subsequently if that doesn't take care of the issue. That seems very reasonable to me in an otherwise low-risk person.
got it. Thank you. And so
Mhm.
we talked about how skipping periods, prolonged cycles are really normal bleeding trends in perimenopausal patients. What are some bleeding patterns that would compel you to order a transvaginal ultrasound or even an endometrial biopsy for further evaluation?
Right. I think that's a really important clinical question, and I don't think anybody will ever regret getting an endometrial biopsy or an ultrasound. So if you're thinking about it, it's probably a reasonable thing to do. But knowing what's normal weird bleeding versus abnormal weird bleeding is useful. And those are not technical terms. That's just my own description of it. But when I see someone in perimenopause, if she is skipping periods and having periods of time where she's going without a period, I'm usually pretty comfortable there. Just, saying this is perimenopause and not getting further imaging or evaluation. What is not normal, perimenopausal bleeding transitions are heavy, gushy, clotty, crampy periods that are just really filling up a pad every hour or two. I don't usually attribute that to perimenopause. And in fact, ACOG talks about the Palm-Cohen mnemonic, which is the way you think about abnormal bleeding. And there's a large differential diagnosis based on that. It's PALM-COEIN, I believe is what it is. And I refer you to the ACOG practice bulletin on that. But it goes through the large differential diagnosis. And hormonal bleeding is in that differential, but other things it could be fibroids, it could be adenomyosis, it could be a polyp, it could be hyperplasia or cancer, it could be a bleeding disorder, it could be any number of things. And so The types of bleeding that you would see with those sorts of things are prolonged bleeding, bleeding 10, 12, 14, 18 days. That's not perimenopause. Completely random bleeding with spotting in between. You bleed for a day, you stop for 2 days, you bleed for 3 days, you stop for a week, you bleed again. That's not perimenopause. Perimenopause is prolonged cycle length, where the period of time in between periods is extended. It's not this random, unpredictable bleeding, heavy, gushy, clotty. That's not normal. So in those situations, I would get an ultrasound and I would do an endometrial biopsy. An endometrial stripe thickness in this setting is not predictive of anything, because in perimenopause, the endometrial stripe can be 22 millimeters, and that's not abnormal because there's so much cycling happening. And so the only time that 4 millimeter endometrial stripe is predictive of anything is in postmenopausal people who are on continuous combined hormones or not on hormones at all. That's the only time that's relevant. In people who are on cyclic hormones, it's not relevant, or people who are not fully menopausal, it's not relevant. But in those postmenopausal people, either not on hormones or on continuous combined, you can use that 4 millimeter endometrial stripe as the cutoff in terms of whether or not to biopsy, with one other caveat, and that is not in Black women. It's not relevant in Black women ever because they have a higher incidence of fibroids and non-endometrioid histology if they do get diagnosed with an endometrial cancer. And so people who are Black, who have abnormal bleeding, never should have an ultrasound for the determination of an endometrial biopsy. They should always be biopsied if you're thinking their bleeding is abnormal. But otherwise, you can use an ultrasound to help you diagnose other types of pelvic pathology. So you're going to want to get it for a fibroid diagnosis or polyps or something like that. But the biopsy itself shouldn't be determined by that 4 millimeter endometrial stripe unless you have that very specific group of patients, again, postmenopausal, either not on hormones or on continuous combined. It's a complicated answer, but I hope I made it clear.
Yeah, those are useful reminders that that 4 millimeter cutoff is not useful during the perimenopausal period if they're not on continuous birth control, and also not useful in Black women.
Exactly.
Okay. And before we jump into hormone therapy, I wanted to ask you, because patients often ask, are there any benefits to certain foods, special diets, supplements to reduce their symptoms that they're experiencing during perimenopause?
Right, and menopause as well. There was a great position statement that came out from what used to be the North American Menopause Society. Now it is the Menopause Society, on non-hormonal treatment of symptoms. And they talked about non-hormonal medications, but they also talked about herbs and supplements and various things. And what they found is that there's really not enough evidence to support anything from an herb and botanical standpoint. So evening primrose oil, black cohosh, red clover, all those kind of substances that people can buy off the shelf really have not been shown to be beneficial for symptom management. Soy is a little bit different in that there have been some good studies that have said that soy supplementation has decreased the incidence of hot flushes and the severity of hot flushes. But the difficulty there is there isn't consistency in the research in terms of how that soy is delivered. So some studies do half a cup of actual soybeans, others do soy protein powder and different things. So there hasn't been enough consistent data to come out to really allow us to recommend soy for that reason. But it's interesting, and, eating soy doesn't seem harmful, and so for some people, that may make a difference in their symptoms, but otherwise, things you buy in a bottle that you take as a pill or something, there's really nothing there that, has shown to be beneficial. One thing I did want to mention, we talked a little bit about the symptoms and diagnosing perimenopause. In terms of treatment, people come in and they really are like miserable, and so if you put a perimenopausal person on traditional hormone therapy, what we used to call HRT, we now call it hormone therapy, or MHT, menopausal hormone therapy. If you give them hormone therapy in the perimenopause in a continuous way, it's about a quarter of the strength of the lowest birth control pill. So it's a very small amount of hormone, and they're likely to have a lot of breakthrough bleeding. It's not enough hormone to suppress the brain ovary cycling. So you're not going to get menstrual suppression. You're also not going to get contraception. And until you've had that last period, and you've had a year of no period, you potentially could have a what they call change of life pregnancy. And so you want to think about your perimenopausal patient's needs. Does she need contraception? Does she need cycle control? Does she just want to know what's going on and she's okay sitting tight? You want to make sure you identify what those treatment goals are and then treat appropriately.
That sounds like individualizing therapy during this transition is really important. And
Mhm.
you mentioned birth control, and I've learned from one of your prior talks that one of the preferred agents might be Yaz to treat perimenopausal women during this time. Can you talk more about that?
Right, right. Yaz is an interesting birth control pill. All oral contraceptives have the same estrogen in them. They have ethinyl estradiol. The thing that makes one pill different from another is the progestin. And Yaz, the brand name Yaz, is ethinyl estradiol and drospirenone, which is a different type of progestin than in the other types of pills. And it's the only one that is FDA approved for treatment of PMDD, of premenopausal men or premenopausal dysphoric disorder, which is, PMS writ large, very severe PMS. So it has a nice kind of beneficial effect on mood disorders at all times of a woman's reproductive life. So we extrapolate that to think that that's going to be the most effective for mood disorders in the perimenopausal mood instability. So that's usually my go-to. And continuous dosing of it is ideal because symptoms tend to recur in the pill-free interval. So when they're taking placebos, so a continuous dosing of Yaz is really a nice way to provide both contraception and menstrual suppression, symptom management, cycle control, all of that. If the patient doesn't really want to take a combined birth control pill, another option is a levonorgestrel containing IUD, which is great for providing, again, cycle control and contraception. And then along with that, you might offer an estradiol patch. Usually I would go to a 0.05 biweekly patch. So a patch and an IUD. Or if you wanted to try hormone therapy, you could do that, but I would recommend cycling with a continuous patch, 0.05 biweekly patch, and then adding the progestin, probably prometrium 200 milligrams, days 1 through 14 of each month. And that would then provide some cycle control for that irregular cycling, but again, would not provide contraception. So birth control pills or IUDs are nice ways to manage perimenopause so that you get contraception as well as symptom management and cycle control.
I see. Good to know that there's a number of options.
Mhm.
So you mentioned menopausal hormone therapy, so I wanted to jump in and talk about safety of hormone therapy. 20 years ago now, the Women's Health Initiative found, and it was widely publicized, that hormone therapy increased the risk of cardiovascular disease and breast cancer. And this really decreased the use of hormone therapy in menopausal women. Could you talk about the findings and flaws from the study?
Sure, sure. And boy, what an earthquake, right? When that came out in the early 2000s, I was in practice then. And that's why part of the reason I'm out here teaching about menopause was I was in the group of people who did get trained, before the Women's Health Initiative came out. But yeah, boy, the phone rang off the wall that day in the clinic, and it was on the Today Show and Good Morning America. And the numbers that hit the paper, the media, were pretty impressive. They were like a 29% increased risk of coronary heart disease, a 41% increase in stroke, a 26% increase in breast cancer. And so people freaked out and kind of all went off their hormones, and it was really quite the firestorm. And that's why 15 years went by and people didn't get trained. And a lot of people went off their hormones, and the ones who did worried about it. But what we know now, we have the perspective of 20 years, and that's been really valuable because we've got more data, we've refined the data. And so now we think of it a little bit more nuanced, in a little more of a nuanced way. First of all, I would say those numbers, those percent increases sound alarming. And when we talk to patients about it, it's helpful to talk about the absolute risk. And when you think about the absolute risk, it's about 8 extra cases of breast cancer or heart attack or stroke per 10,000 women. So, and when people hear that, they think, oh, 10,000 women, that's like half a football stadium, 8 extra cases, that's not that much. And especially when you think about breast cancer, the risk is greater with a sedentary lifestyle or alcohol intake or obesity than it is with estrogen. And we have so much control over those things, and we don't tend to fear, that nightly glass of wine in the way we worry about taking estrogen. So helping people put that in perspective is, I think, really super important. And when I say alcohol intake, I mean more than 1 glass of wine per night for a woman. So anything more than 7 drinks per week will increase her risk of breast cancer. And obesity increases the risk of breast cancer by 9-fold. So, talking with our patients about that, I think, is really super important. In the 20 years since the Women's Health Initiative, there have been no increased breast cancer deaths in people who have taken the hormones, nor there has not also, I've got double negatives going, there also has not been an increased risk of deaths from cardiovascular disease in people who have taken hormones. And there has been a decreased all-cause mortality, death from all causes in people who are taking hormones. So that's, I think, also important data now that we have in terms of follow-up. The other thing that I think is important to keep in mind is now we know that younger women behave differently on hormones than older women. And when you think about who was enrolled in the Women's Health Initiative, they enrolled women between the ages of 50 and 79, and they had not been on hormones. So they were starting women in their 70s on hormones. And guess what? When they stratified the data by age, the people who were under age 60 when they started hormones or less than 10 years out from their menopausal transition behaved very differently on hormones than those older women. They had fewer heart attacks, strokes, and cardiovascular events compared to the older women. So now the sort of more modern menopause management is if somebody does not have any absolute contraindications to being on estrogen and they're under age 60 or less than 10 years out from menopause, not only are they going to get symptom management, but they're going to have a healthier heart and they're going to have bone protection. So there's not only symptom benefits, but there's also long-term health benefits. Although the U.S. Preventative Services Task Force gives prevention of chronic conditions a grade of D for hormones. So we don't give hormones just because we think they're going to have a healthier heart, but 80% of people are hot flushing. So you're going to want to give them hormones anyway, and then they are going to accrue those benefits. So that I think is really important, because if you're under 60 and less than 10 years out from menopause, or less than 10 years out from menopause, you can feel pretty confident in the absence of absolute contraindications that you're going to get benefits.
Great. Yeah, thank you for those great counseling points. I think it's always hard to kind of convince patients of the benefit risk ratio. So keeping in mind that the absolute risk increase is only about 8 in 10,000, that obesity, being sedentary, drinking more than 1 glass a day are bigger risk factors for breast cancer is so important to tell our patients.
Absolutely, absolutely. And I think it's hard as a clinician to really parse all that out and have that conversation with people when you're also wanting to make sure their Lipitor is managed, and all the other things. So I would just encourage clinicians to say, boy, menopause, that's an important topic and really an important conversation. Let's get you back in relatively quickly and have that conversation, because boy, if you've got a 20-minute follow-up visit and you got 6 things they want to talk about, this is a lot. But if you can work on your talking points and say 8 extra cases per 10,000 women, these are the other things that are increasing your risk for breast cancer. So keep it in perspective. And then maybe we'll put you into the ASCVD calculator. We'll help you figure out what your overall risk is for cardiovascular conditions. And really, if somebody's got a low or moderate cardiovascular risk, I don't have any problem putting them on hormones, and especially if they're under 60. So yeah, I would just say your practice pearls are: give this the time it deserves. Maybe consider having them come back for that follow-up. Don't hesitate to start your low-risk people on hormones and then have them follow up with a gynecologist. That would be fine to do. Refer for the complicated people, but really, I think getting familiar with your preferred approach for hormone therapy, which for most of us is a transdermal and either an oral progestin or an IUD, and getting comfortable with that is absolutely within the purview of a primary care person.
You mentioned using a risk calculator to think about cardiovascular risk, and I'm just curious, do you ever use a risk calculator such as the BCSC score to decide if the benefits of hormone therapy might outweigh the risks of breast cancer?
Oh, you mean like the Gale model or
Yes, the
the?
Breast Cancer Surveillance Consortium, or anything to help you determine if someone has a family history of breast cancer. Sometimes they'll ask me, oh, I don't have a personal history, but I have, my mom had breast cancer at 70. Do you still think hormone therapy is right for you? How do you generally
Yeah.
navigate that?
Yes, exactly. So absolute contraindications for hormone therapy are if the patient themselves has breast cancer. Most of us would not give that person hormone therapy, even if they're triple negative, because even if their breast cancer is triple negative, if it metastasizes, they have about a 20% chance of having the metastasis become hormone receptor positive. So most of us don't touch we don't give hormones to people who have breast cancer. That's just in general, other than local. If it's in the vagina, it's a tablet or a ring or cream that doesn't absorb into the bloodstream, and we don't consider that a contraindication. But for systemic hormones, breast cancer, if the patient has breast cancer, not a family history, and we'll talk about that, a person who has had a heart attack or a stroke, somebody who's had a cardiovascular event, someone who has had a blood clot, a DVT, a venous thromboembolic event, a PE, something like that. Those are the broad categories. Also, active liver disease would be a contraindication for oral, gallbladder conditions. So those are sort of the big contraindications. Breast cancer risk is complicated and nuanced. And so that conversation really has to be, you have to tease out what the patient's concerns are. And so a family history, even if she's BRCA positive, is not an absolute contraindication. but most of us use some type of Gale model or the Tyrer-Cuzick model to help stratify that breast cancer risk. If they're low risk, we usually do consider hormone therapy. If they're moderate risk, you can. If they're high risk, in general, we tend to avoid. And high risk would be over 20% lifetime risk of breast cancer, according to whatever, pick your model that you like to use. Tyrer-Cuzick does tend to come back with a higher risk score than the Gale model because it factors in many generations of breast cancer history and things like that. So that's important, I think, to talk to your patients about, especially since the BRCA positive patients often have surgical menopause. They've had their ovaries removed and they're going to be wildly symptomatic. They're going to be hot flushing in the recovery room. And so you have to really think about that and talk about the pros and cons of starting on hormones. If you choose to start on hormones, then I think that that is a very appropriate thing to do for a few months, see how the patient assesses the quality of life versus their fear of breast cancer and how do they feel being on it. You know, they're the ones who have to kind of live in that body. But many of my patients are perfectly comfortable once we've had the discussion going ahead and being on it, at least until the average age of menopause or until we decide that it's time to stop and we have that conversation together to figure that out.
Great. So it sounds like it's really important to keep in mind that family history, even being BRCA positive, is not a major contraindication, and using one of these models can be very helpful to help us decide.
Exactly,
Yeah.
exactly. And
And
it's always a risk benefit discussion. You know, this is, I think, where the art of medicine really comes in because, you know, you could have two patients who have exactly the same situation and treat them differently based on what the patient's priorities are. So that's, I think, a really important point. And yes, I'm glad you clarified that. Mhm.
And so, sometimes women ask if starting hormone therapy is going to help with all the other symptoms they're dealing with from perimenopause, the weight gain, the insomnia, the mood fluctuations. What should we tell them?
Right. I try to under-promise and
Mhm.
over-deliver. Just in general in my life, you know? And so I feel very comfortable telling people your hot flushes and night sweats are going to improve dramatically. They may not go away completely, but they will improve dramatically. If you're having vaginal symptoms, the vagina loves estrogen, and that will also get better. You know, now not if they've got recurrent yeast infections or something. So you want to sort out what the vaginal symptoms are and what do you think you're really dealing with genitourinary syndrome of menopause? If you're dealing with dryness, pain with penetration and sexual activity, feeling like they have a UTI all the time and their urine is negative, those symptoms respond beautifully to estrogen. You get about a 65 to 70% improvement in the vagina with systemic hormone therapy. So you don't even have to give them local necessarily. If you're doing a patch and a prometrium pill or a patch and an IUD, you're going to see about 60 to 70% improvement in the vagina with that. And that may be all they need. So I usually wait on adding local estrogen until I've seen them back in 6 weeks and see if it's made any difference. So hot flushes and vaginal symptoms, I feel comfortable promising that that's going to get better. Most of the time, mood gets better. Most of the time, sleep improves. Most of the time, joint pain improves. Isn't that interesting?
Yeah.
50% of perimenopausal people report myalgias, musculoskeletal symptoms, joint pain, and you know the data is starting to accrue that that gets better with hormone therapy. So so I feel pretty comfortable saying I hope you're going to sleep better. I hope your mood gets better. I hope your joint pain gets better. So, but we'll get back together again in 4 to 6 weeks and see how that's going. Libido, I wish. Right? And that's a whole nother talk. I think
Yeah.
you had a talk on that. Estrogen does not have an independent effect on libido other than its ability to treat pain. So I always say it's totally normal not to want to do something that hurts. And if you're having pain, we need to treat that, but it's not going to get your 30-year-old libido back, or, I wish it would. And so, that I don't promise it's going to help brain fog, although sometimes it does. And that often is because people are sleeping better. And so it's hard to say, was that a primary effect, on cognition, or is it just she's sleeping better and her mood's better, therefore she's concentrating better? So, I usually just say, this is what I expect. Let's get you back and let's see how you're feeling and see what's better and what isn't.
Great. And let's jump to kind of the other spectrum. So, sometimes we think that, we have to really cut off the hormone therapy after 5 to 10 years or once someone turns 60. Can you talk about discontinuation when you start to have that risk communication with the patient?
Right, right. So this is really an important point as well, because this is not one of those situations where you're going to say to the patient, you're all good, come back in 5 years for your pap smear, because it's always a risk benefit discussion. So when I have someone on hormones, even if it's just local estrogen in the vagina, I want to see them once a year for sure. And sooner, if anything changes, if they're having issues or questions, I know I want them to be able to reach out to me. But once a year, I want to look at their health history. Has anything new happened in the past year? Do that risk benefit discussion again and make sure that we're figuring out what we together think is the right thing for that patient. It's really unfortunate that we don't have any guidelines as far as how long to keep someone on it and when to stop. Most people feel pretty comfortable with the 5 to 7 year window for sure, because that's really when we started to see a little bit of an uptick in the breast cancer cases. But there's no age at which we automatically stop hormones. And, at age 65, it's on the Beers criteria for Medicare, which is unfortunate. It's like, these are high risk conditions that you should, or high risk drugs that you should stop after age 65, and hormone therapy is still on it. We can't get them to take it off. But there's no clinical guidelines that say we should stop hormone therapy at age 65 or at any particular time. It's always that risk benefit discussion. And, I have some people on it in their 70s, and I think it's very different starting someone at age 50 and keeping them on it through their 70s versus starting someone at age 70. There is no benefit to starting someone on hormones more than 10 years out from menopause or after age 65. Most of us would not do that. It tips toward risk to start someone at that stage of things because it destabilizes the plaques in the coronary arteries. And that's why we think those people had more heart attacks and strokes and clots, because they were started at a later age. And so starting someone after 65 not only confers pretty significant cardiovascular risk, it also increases the risk of dementia. Some authors say by about a third. Some people say it doubles the risk of dementia. So not starting de novo after age 65, but continuing, we think, is a very different situation. And although we don't have the data to support us on that, most of our clinical experience shows that to be the case, that people do quite well starting at the age of menopause and then just staying on it.
I think that's important to remember, that there's not necessarily an age where we have to start taking the hormone therapy off, and to really also individualize that transition.
Right. I love how you summarize my paragraphs.
It
Thank
helps me
you.
remember.
I appreciate that so much. You're such a great listener. I'm so impressed at how it's like we should write this in a paper, right? And then I write all the blah, 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 and you write the take-home messages.
And then I wanted to spend our last few minutes talking about non-hormonal treatments. Earlier, you nicely outlined all the contraindications to hormone therapy. And so for those patients, what are some of the non-hormonal options that you go to?
Yes, and so it's just so wonderful that we have something better to offer those patients than we used to. It used to be really a tough conversation to have with our breast cancer patients who are hot flushing and night sweating and really uncomfortable. And we just say, we just estrogen's off the table for you. Now we have a new drug that was FDA approved last May. It's the first drug in its class. It's called fezolinetant. It is a neurokinin B blocker, and so it's non-hormonal. It works in the brain at the neurotransmitter level before it ever gets to FSH and estrogen and all of that. So it works in a very novel way. It's a once a day dosing, which is super easy, which is nice. The only people who should not take it are people who have end-stage renal disease or people who have liver function abnormalities, liver disease, because in the trials, people who were put on this drug, a small percentage of them had an increase in their liver functions. So when you start someone on this medication, it's 45 milligrams a day. You want to follow liver functions at 3 months, 6 months, and 9 months. And if it's going to go up, it typically goes up in that window of time. If you keep people on the drug, a certain percentage of them will resolve and their liver functions will go back to normal. So you don't automatically have to take them off. But if they're elevated at 9 months, you want to continue following that at 3-month levels, at intervals. And then if it's persistently up over the next couple of times, then you want to discontinue the drug. So, but it works almost as well as estrogen to treat vasomotor symptoms. And that's been a real game changer because SSRIs and SNRIs, the other ones we typically offer for hot flush management, really in the trials, in people who were having 10 hot flushes per day, with SSRIs or SNRIs, it went down by, on average, 1 or 2. And so they went from 10 to 8 or 9 a day, which, is pretty underwhelming, right? Particularly when you think about the side effect profile of SSRIs and SNRIs and the sexual dysfunction that people get with it. So my other go-to, the one thing about fezolinetant is it's super expensive, and as most new drugs are, Medicare doesn't cover it, and a lot of insurances don't. However, there is a coupon online, and people can go online and download the coupon, take it to the pharmacy, and that does bring the cost down. And the coupon is renewable, so it's not like a one-off. They actually can continue to use it, but we are looking forward to the time when a generic is available. So if fezolinetant is an option for your patient, that would be my first choice. My second choice is usually gabapentin. And I don't know, Dr. Hung, do you use gabapentin in your practice for vasomotor symptoms? Have you found it to be effective, or do you have any experience with it?
Yeah. I always like using drugs that have a 2-for-1 purpose. So particularly if someone is having difficulty sleeping with their hot flashes, they're mainly hot flashing at night, I will reach for gabapentin QHS to start with. And I'm curious what doses you have found to be most effective for gabapentin for vasomotor symptoms.
Right, exactly. Oh my goodness, when I was a new practitioner in this realm, I read somewhere that I don't know, 2 or 300 TID was good for hot flushes, and I started someone on that, and they could practically not get up out of the chair. They were so dizzy, and so I learned, oh dear, I learned, as we all do at the beginning, in that non-hormonal position statement that the Menopause Society published last year, there's a lovely table that I refer people to for pharmacologic non-hormonal therapies and how to start people on them and how to dose it. So I refer you to that. And I follow those guidelines. I wish I had had those guidelines back as a young practitioner. So you start with a dose at night, and depending on how well you think your patient would tolerate it. You have to balance. You want them to feel better pretty quickly, but you don't want them to have a lot of side effects. So you start with a dose at night, and you can pick 100, 200, or 300. I usually feel pretty comfortable saying 300 at night in a one-time dose, because the main side effect is going to be drowsiness, and you want them to sleep. So that would be fine. But if you want to be extra cautious, you can start at a lower dose. And then if you do the lower dose, I give it about a week. And then if they're tolerating it and I feel like I need to bump the dose up, then I add a dose in the morning and have them do that for a week. And then if I still think they need more, then you can do morning, midday, and evening. But people forget that midday dose. And so I tend to try to stick with a morning and an evening dose, and bump it up if I feel like they can tolerate a higher dose. So 100, 200, 300, 300 BID is usually a pretty good dose for managing vasomotor symptoms. So, but it's a project, right? Starting them and increasing them and all of that. So I'm just really happy that we have fezolinetant now to offer. There's another drug in that category that's going to be coming out. It's in phase 3 trials now and is coming to market, and it's called elezonitant. I believe I'm saying that correctly. And it is actually very promising in terms of sleep as well as vasomotor symptoms. So stay tuned for that one. That one's going to be coming to market probably in the next year or so. And that may give us a little bit of a twofer there to be able to treat the vasomotor symptoms and improve sleep.
Yeah, and you were right at the beginning. I wish we had 4 or 5 hours to delve further in.
I
But
know.
I just wanted to thank you so much for your advice and wisdom that you've shared with us during this hour. It was a pleasure to talk to you as always.
Oh, it's my pleasure, Dr. Hung. Like I say, I bow to you. I think what you do is amazing. And I guess our take-home message to our audience is find your collaborators, find the people who will help you take good care of these patients and work together. And I'm always delighted when somebody sends me an email or shoots me a patient chart or texts me and says, hey, what would you do? I just think that's what we should do for each other. And so at Stanford, we're working on ways to formalize that so that people have access to that expertise in the menopause realm like they do in some other e-consults and things. So I'm looking forward to building that as we go forward. And thank you so much for the opportunity to have this time with you. I really enjoyed it.
Thank you.
Bye-bye.